So the problem that I see in clinical practice a lot is people may recognise these things and they'll say, okay, we need to strengthen up through the traps, he needs to get a big middle trap and his lower trap could be better, and maybe he's got a weakness of his serratus. And so what they'll sometimes start to do is some weight-bearing type exercises, because we know, so for example, a push-up plus excuse me, is a great way to get serratus anterior activity. The problem is, from a glenohumeral point of view, a push-up plus really closes down that subacromial space. It does put a lot of stress on your rotator cuff, and in a lot of situations, people with poor serratus actually can't control that position. So it's not a great place to start. And the other thing to consider is, a lot of the time, it's not about retraining middle traps and lower traps and serratus by doing push-up type exercises, or, you see your YTW type exercises with people in prone. That's a really common thing that the people will get given as well. Again, fine later down the track, but in the early stages, a lot of the time what you're actually trying to do is get the middle trap, the upper trap, the lower trap and your serratus to work as upward rotators. And so when you've done your assessment, and if I just quickly remind everyone, and you've found that by facilitating upward rotation to start and then facilitating upward rotation, for example, throughout the movement, and that's taken the person's symptoms away, then you say, well, how do we retrain the muscles to do that? And so what I would suggest is, it's not by getting them to do a really non-specific movement like a push-up or a YTW, a prone sort of retraction type exercise. The best way is actually to get them to work as upward rotators. Okay, so there's a number of different ways you can try it. So the way that I like, and this is again very dependent on your patient, whether they can control this, whether they have enough neck stability to do this. So I'll talk about some patients that might have trouble with this as well. But what I like to do in the very beginning with a lot of shoulder patients, if they can control it, is an upward rotation shrug. Okay, so the way that we do this, and what I usually do, is get a person in front of a mirror so they can kind of see what they're doing. And I'll explain to them, okay, Michael, what I want you to do is just rotate your thumb out like you're hitchhiking. So then people remember that their thumb's externally rotated. And you're not really excited hitchhiking, you're just cool hitchhiking. So you're just down here. So you're not waving around up here, but you're really being cool about it. So you're at about 30 degrees, okay? And then the cueing I give is, take the tip of your shoulder, and I usually touch the shoulder as well, because I think that is nice proprioceptive feedback, the tip of your shoulder towards the back of your ear, okay? And then I'll sometimes do a demonstration. So that's the movement that I want you to try, Michael, and then just to hold and hold there. And so what hopefully you see is this upper trap activity here, and not too much levator scap activity. So you should see levator scap that lies here really kind of hollow out, okay? And you can see that quite nicely there. You'll see his mid-trap working quite hard, and in a lot of situations, even if you can't see it, you can feel the edge of the lower trap, and you can feel that working as well. So we've done EMD on this, and it's been published, but it's a really nice way to get quite a bit of activity of all of your upward rotators, including your serratus. And you're working them as upward rotators then. Okay, so you're not working them as retractors or protractors in the case of serratus, and then relax down. And so I'm not going to get him to hold it that long normally, but I do get them to do a bit of a hold. Again, you can vary this dependent on what you're seeing with your patient, but you'll be surprised at how easily people fatigue with such a easy sort of exercise. So just do that again for us, Michael. So you want to see this upper trap without the levator scap. If they're getting just elevation, that's a problem. If you're getting thickening around this levator scap area, that's a problem as well, because it just means they're elevating. Because a lot of people have a tension through that levator scap, particularly with shoulder pain. The levator scap's really trying to act as a stabilizer. We'll let you relax. Really trying to act as a stabilizer, and it's not a great stabilizer because it downwardly rotates the scap. If you're in downward rotation, you get a lot of that tension through the neck. You get a lot of trigger points through the levator scap, and that's where people have a lot of problems with the neck and then with headaches and and the shoulder sort of symptoms as well. So we can get, and people always worry about upper trap, but a lot of the time it's not upper trap that is the problem, it's this levator scap. So understanding where the borders are is actually really important as well. So if you're getting nice upper trap activity, that's what you want. So you don't want to diminish the upper trap activity, because for a lot of people in the early stages, that's the only thing that they've got upwardly rotating their scapula. Yes.
Do you have any cues for if you're seeing a lot of levator scap in there, how to get rid of that?
Yeah, I think if you're seeing that, that's a great question. It's really that they're not getting that upward rotation. So they're not rotating the scapula, they're just elevating it. So you can use some manual facilitation, absolutely, and just try and help them facilitate that and get them to do it a number of times. I get them, as I said, looking in front of the mirror, so I want them to see this bulging. I want them to see what's happening even just from the trunk point of view.